Hey everyone, and welcome to this explainer. Today we are diving headfirst into a true medical mystery, anterior uveitis. We're going to be acting as medical detectives, tracing the pathology from a tiny, localized microscopic breach in the eye all the way to some massive, whole-body systemic masterminds. Let's get right into it.
To really understand this disease, we first have to step back and ask ourselves a pretty major question. What actually happens when the heavily fortified walls that separate the eye's pristine, crystal-clear internal environment from the chaos of the rest of the bloodstream suddenly just collapse? I mean, it's literally a microscopic disaster, but it has some very macroscopic consequences.
So let's start by defining our primary suspect here. Uveitis is an intraocular inflammation restricted entirely to the uveal tract. And just to put things into perspective, anterior uveitis makes up an overwhelming 80% of all these cases. We are not talking about some standard surface infection like conjunctivitis. No, this is an internal inflammatory war that is completely 100% restricted to the intraocular space.
Okay, Section 1, the eye's security wall. Think of the blood-aqueous barrier, or the BAB, as a highly secure biological dam. Its entire job is to strictly segregate the blood from the aqueous fluid, and it does this using tight junctions. These microscopic seals are strategically located in the ciliary non-pigmented epithelium and the non-fenestrated endothelium of the iris capillaries. As long as these junctions hold the line, the eye remains optically clear and totally protected from whatever systemic chaos is going on in the body.
Section 2. When the barrier breaks.
Now this is where things get really interesting. What actually happens when those vital tight junctions are destroyed by inflammation? Well, we observe a very specific, sequential breakdown. Step 1. The tight junctions fail. This failure essentially opens the floodgates, allowing massive macromolecules, we're talking plasma proteins and fibrinogen, to just passively leak right into the eye. Step 3 is an active invasion. White blood cells, or leukocytes, extravasate into the fluid, completely driven by inflammatory chemoattractants. And finally, substance P drains via the trabecular meshwork straight into the conjunctival veins. This cascade completely rewires the eye's internal chemistry. And of course, this chemical breach leaves some very clear early physical evidence. That drained substance P, it causes painful pupillary spasms, giving the patient a myotic, super sluggish pupil. You'll also see a violaceous circumlimbal flush, which is basically this deep, angry red ring right around the cornea. Meanwhile, all those leaked proteins create what we call a flare in the anterior chamber. If you've ever seen dust floating in the beam of a movie projector, it looks exactly like that. Plus, the invading white blood cells give you active, undeniable proof of inflammation right there in the microscope.
Moving right along to Section 3, spotting the warning signs.
As we continue our investigation, we start cataloging the specific physical signs left behind. Look at how cellular debris literally gets stuck to the back of the cornea, forming what we call keratic precipitates, or KP. And in cases of a much more severe barrier breakdown, you get a hypopeion. That's that dramatic, gravity-driven settling of white cells and heavy fibrin right at the bottom of the eye. When you see that, you know you're dealing with an aggressive disease that needs immediate attention. Now, if you leave this unchecked, that stagnant, fibrin-heavy fluid starts acting like a biological glue. I mean, literally. The iris can actually adhere right to the lens, forming posterior synechiae, or it can stick to the cornea in the angle, creating peripheral anterior synechiae. This is incredibly dangerous because it can rapidly lead to a pupil block, sky-high intraocular pressure, or even permanent damage to the trabecular meshwork that you'd need a specialized gonioscopy exam just to assess. You might also spot secondary cataracts or a nasty calcium deposit known as band keratopathy.
Section 4, acute versus chronic attacks.
So a crucial takeaway here is that not all inflammatory attacks follow the exact same playbook. You have to differentiate between two completely distinct clinical profiles. Acute anterior uveitis hits suddenly. It's like a blaring car alarm, severe pain, intense redness, photophobia, and these small, fine KPs settling in a triangular pattern known as Art's triangle. Chronic uveitis, though, that's your silent infiltrator. It's insidious. It often leaves the eye looking completely white and is frequently totally painless, which makes it terrifyingly easy to overlook unless you are actively hunting for it. And when we look deeper, down at the cellular level, acute presentations are typically non-granulomatous. They're driven by neutrophils and lymphocytes, which give you those fine KP we just mentioned. Chronic presentations, on the flip side, are often granulomatous. This means the primary culprits are macrophages and giant cells. They leave behind these large, greasy deposits we call mutton-fat KP. You might even see visible inflammatory nodules forming directly on the iris stroma or right on the margin of the pupil itself. All right, Section 5, the systemic suspects.
Here is where this localized little eye problem transforms into a massive, whole-body mystery. It sounds crazy at first, but you really have to ask yourself, could a sudden, painful, violently red eye simply be a flashing warning light on the body's dashboard, pointing to a hidden, systemic autoimmune mastermind? Because very often, the eye is just the first alarm bell to go off. Take a look at this master roster, mapping out our systemic suspects. Notice how they're grouped by the presence of the HLA-B27 genetic marker. HLA-B27 positive diseases literally connect eye inflammation directly to conditions affecting the spine, the joints, the skin, and the bowels, things like ankylosing spondylitis and Crohn's disease. On the other hand, HLA-B27 negative diseases point us to entirely different culprits, like Behçet's disease, juvenile idiopathic arthritis, or infectious causes like syphilis and TB. It's like a giant puzzle.
Let's look at a prime example of this in action. Say you have a young male presenting with recurrent acute uveitis. He might actually be suffering from ankylosing spondylitis. This is an HLA-B27 positive condition that notoriously causes lower back pain, but oddly, it's pain that actually improves with exertion. If left unchecked, it eventually leads to a rigid, fused bamboo spine. In this case, the eye is actively giving away the spine's deepest secret.
Conversely, what if you have an HLA-B27 negative patient with a sudden hypion? Well, if that hypion is uniquely fluid and shifts easily whenever they move their head, it might point straight to Behçet's disease. This is a very severe multi-system disorder often seen in young males of Eastern Mediterranean or Japanese descent, and it brings along painful oral and genital ulcers. The clues in the eye perfectly match the systemic profile.
And of course, we absolutely can't ignore the rule breakers. Juvenile idiopathic arthritis, or JIA, causes a sneaky, chronic, but surprisingly non-granulomatous uveitis in kids, which makes mandatory screening within 6 weeks of diagnosis absolutely essential. Then you have Fuchs uveitis syndrome, which silently strips the iris of its pigment without ever forming those sticky synechia. And don't forget that certain drugs, like lanaprost or even bisphosphonates, can actually induce uveitis all on their own.
Which brings us to Section 6, solving the case.
So how do we actually synthesize all this evidence and treat this multi-layered threat? It requires a really strict methodical protocol. First, you have to identify if it's acute or chronic based on the patient's history and the look of those KP cells. Second, you must aggressively stain the cornea to rule out surface masquerades like ulcers. Third, always dilate the pupil to check for posterior segment involvement. You do not want to miss a tumor or a detachment. And finally, refer the patient appropriately for a full systemic workup.
Once that diagnosis is locked in, primary management is really a delicate balancing act, using heavy topical corticosteroids to aggressively crush the active inflammation. Alongside that, you're dropping in cycloplegics to literally freeze the pupil in a dilated state. Why? Because it stops those painful pupillary spasms and totally prevents the dangerous synechial adhesions we talked about earlier. For really stubborn cases, periocular injections might be necessary, and that requires tight, seamless coordination with GPs, rheumatologists, and ophthalmologists.
Which leaves us with a pretty fascinating realization to ponder as we wrap up this explainer. Think about it. If simply peering through the cornea to spot a single inflamed cell can unravel massive, complex systemic diseases like Crohn's, arthritis, or tuberculosis, what other huge internal alarms are we totally missing when we only ever look at the surface of a symptom? Keep looking deeper, everyone. Thanks so much for joining me on this explainer, and I'll catch you on the next one.